A 45-year-old woman presented seeking treatment for pain in her maxillary right molar region. She declared that pain was provoked by chewing and by cold and sweet stimuli. Recently, pain had become spontaneous, particularly at night, projected to the posterior margin of the mandible. She indicated her first molar as the tooth responsible for pain when chewing, but she was not able to indicate which tooth was sensitive to cold. A zirconia crown was present on the first molar, which was mobile. Periodontal probing showed pockets exceeding 10 mm buccally and palatally, owing to the diagnosis of vertical root fracture of the first molar. TMJ disorders were recognized with clicking and restricted jaw motion. The radiograph showed a deep mesial caries cavity on the maxillary third molar, close to the pulp chamber. No periapical radiolucencies were present. Thermal pulp tests for this tooth gave exaggerated responses, with pain ceasing 10-15 seconds after removal of the stimulus. The tooth was not tender to percussion. Given the presence of TMJ disorders, the spontaneous pain projected to the posterior margin of the mandible could not be clearly attributed to a possible irreversible pulpitis of the third molar, for which reason the diagnosis of the pulp status of this tooth remained uncertain. Treatment plan encompassed extraction of the first molar. Given the limited mouth opening and absence of the mandibular third molar, extraction of the maxillary third molar was also decided after discussion with the patient. The patient gave consent for histological examination of this tooth. After extraction, photographs of the mesial aspect revealed that caries had extended beyond the cementum enamel junction. Like in all cases where we want to study the reactions in the pulp chamber tissue, special precautions have to be undertaken to allow adequate pulp fixation. Simple immersion of the tooth in formalin would not allow penetration of the fixative in the pulp with obvious artifacts. Therefore, the roots are separated from the crown approximately 3 mm beyond the orifices with a diamond disc. A plan is prepared with a high-speed diamond burr under magnification until 1 or 2 pulp horns are encountered. At this point, the crown and the roots can be immersed in the fixative. We use a 10% neutral buffered formalin solution for 48 hours. Demineralization follows. The specimens are placed in plastic boxes. These are labeled and placed in a basket, suspended in a big container with a decalcifying solution. We use a 22.5 formic acid sodium citrate solution. Demineralization is accomplished in 4 weeks. The specimen is washed in running water for 12-24 hours to remove acids. Dehydration in ascending grades of ethanol follows, clearing in xylene, and finally infiltration with paraffin. The specimen is embedded in a paraffin block oriented parallel to the prepared sectioning plan. Microtomy follows. Serial sections are cut. The ribbon with a certain number of sections is placed in the paraffin bath. Sections are collected on special slides. These are dried on a warming table, placed in the paraffin oven, and finally stained. Microtomy is completed when the whole volume of the pulp chamber has been exhausted. As a consequence, a large number of sections are cut. Random sections are not accepted for histologic investigations. Slides are stained alternatively with hematoxylin and eosin and with the tailor-modified brown and brain technique for bacteria. The stained slides are observed in the light microscope and photomicrographs are taken. Histologic slides show in all the sections of the series that caries had not penetrated the pulp tissue, with a band of tertiary dentin produced on the pulpal side. Pulp stones in the pulp tissue. Reduction of odontoblast layer and pulp inflammation, but not necrosis. Circulatory disturbances in the pulp tissue with fibrin precipitation in vessels. Lots of bacteria in the caries dentin. Hyperemia in vessels. Circulatory disturbances are also demonstrated in H&E stained sections. In no section necrosis is observed, owing to the histologic diagnosis of reversible pulpitis. Conclusions. Observation of serial sections allowed the histologic diagnosis of reversible pulp inflammation. This case exemplifies one of those conditions in which the clinical diagnosis of the pulp status is uncertain, and the precise diagnosis can be established only after histologic analysis. In fact, the concomitant vertical root fracture and the TMJ dysfunction had a confounding effect on the diagnosis of the pulp conditions of the third molar. In the Ricucci et al. 2014 article, it is concluded that, despite the good correlation between clinical and histologic diagnosis, there are still few cases in which the clinical diagnosis does not correlate to the histologic diagnosis. This has to be kept in mind by the astute clinician.